Good morning, everyone. Can you all hear me? Excellent. All right. If I get too loud or too soft, just yell, "We can't hear you," or pipe down, "You're too much, Chandan." Okay. I've heard that a lot of my life. So hello, everyone. Welcome to our session, Mentorship as Allyship, Transforming CL Psychiatry through DEI-Informed Mentoring. This is co-sponsored by the ACLP Mentorship and DEI subcommittees. And especially after how DEI and mentorship have been highlighted at this meeting's plenary sessions and awards so far, we're so excited to be presenting this to y'all. Please come on, take a seat. Special hello and shout out to the people joining us virtually from around the country. And let's get started. So, none of us have any disclosures. And a brief overview of the agenda. So first, we're going to do a couple of word clouds to explore your perspectives on some of these principles. Then we're going to do a brief literature review around mentorship and DEI. We're going to then break out into two small groups, so basically sides of the room, and we're going to make you interact, like take advantage of that live in-person meeting. And talking about two very interesting cases that you may have run across in your own experience. Then we're going to come back as a large group, and two representatives from the groups are going to talk about what they found, and that'll open up the discussion to the larger group. We'll then talk about trauma-informed mentorship strategies and take lessons from a model mentorship program. And then finally, at the very end, we're going to have a small commit to change exercise. So you may ask, why does it just say word cloud number one? It's because I'm going to very high-techly switch over to a Google Chrome and then go into presentation mode. So if any of y'all have done a word cloud before, it's pretty exciting. So if you just go to www.menti.com on your devices, and then you put in the code 19590372. It'll then ask you, what are three words that come to mind when you hear the word mentorship? And what will happen is as you input entries, it'll show up on the screen live. And the bigger concepts, the ones we think of more, will show up more in the middle, and then it'll kind of branch out from there. So take some time right now, go to www.menti.com, enter a code, and think up to three words. When you hear mentorship, what do you think? Yeah. And for people who can't read because the screen's so small, it's Menti, so MENTI.com. All right. This is pretty exciting. So you're seeing here some ideas are starting to crystallize now, but then even more is coming around across the periphery. For those joining us virtually, you can also do this from the comfort of your own homes and offices. And at the end of the presentation, I'm going to upload this final product to the final version of the slides so we can have you all have it for your own records. So what we're seeing right now is when people hear mentorship, they're thinking concepts like guidance, support, role model, leader. I'm seeing around the edge like sounding board, like building up. Supervision, like encouragement. Okay, great. Now we're going to do our second concept. What are the first three words that come to mind when you hear the word allyship? All right, so when we are hearing allyship as a field, we're thinking support, advocate, partner, understanding, encouragement. Around idea, engagement, community, team, champion, skin in the game. Right. So the reason we're asking you to do this, apart from just showing off the coolness of a word cloud, y'all should really be doing it in your talks, it's super fun, is going back to this. So based on what you were seeing in these words clouds, what is the relationship y'all are seeing between mentorship and allyship? This is not a rhetorical question, literally, just like feel free to like shout it out or go to the mic and I'll try to repeat it back for the folks at home. Like looking at these word clouds, like what we are thinking as a field when we think of mentorship and allyship, what is the relationship? Are there contrasts, are there similarities y'all are seeing with both? Wait, go ahead. Excellent. Thank you so much for sharing. So to repeat, got a comment, mentorship has more of a hierarchical feel to it, while allyship tends to have more of like a partnership feel to it. Okay? Anything else people were noticing? Mm-hmm. So great comment made as well, like both of them have elements of advocacy, standing up for the person you're working with. Right. Anything else that people noticed? So we're seeing like differences, but also some striking similarities between the two concepts. Please go ahead. Support is central in both of these concepts. Right. So thank you all. So moving on, like we're going to now define what is mentorship and allyship. I volunteered for this section and I kind of regret it because mentorship has more than 50 definitions. Like it is one of those terms where like you think you know what it is, but then you just dig deeper and deeper and deeper. And so somewhat concise definition is a professional relationship in which a more experienced person, mentor, guides a less experienced person, mentee, in professional or personal growth. Note that I make no mention of seniority or age or rank. It has to do with more experience and less experience. So it could be a senior person and a junior person. There's peer mentorship where people of equal standing may have differential experiences or expertises in activities. A mentor is not the same thing as a boss or leader, and not the same thing as a patron or sponsor. So speaking of sponsorship, this is an interesting graphic, like mentorship versus sponsorship. Mentors develop while sponsors drive forward. Like mentors support by giving advice, saying like, hey, you should consider doing this, while sponsors promote, being like, here's an opportunity, I want to put your name in the hat for this. Mentors encourage advancement by saying, hey, this is how I want to help you meet your goals, while sponsors enable advancement by giving them things like promotions and seats at the table and recommending them for awards and positions. Lastly, mentors offer insight like, hey, this is how I think you can move things forward, while sponsors really champion visibility. Like, hey, look at my sponsee, like they're awesome, y'all should check them out. So again, related but very separate concepts. So transitioning now to what is allyship. Again, some backstory, allyship wasn't even a word per se until 2021, formally. And I was also the same year, it was word of the year for dictionary.com, just showing its huge prominence now. in the mainstream. So traditionally, it was just persons, groups, or nations associating, cooperating for a common cause or purpose. But now really we're looking at is the status or role of a person who advocates and actively works for the inclusion of a marginalized or politicized group, not as a member of that group, but in solidarity with its struggle and point of view and under its leadership. So 4 big principles are asking questions, listening, showing up, and speaking up. And note that this is an active, intentional, ongoing process. There's a lot of humility involved. You will make missteps, and your job is to own up to it, apologize, and then keep moving forward. Right? This is where we have the term ally is a verb. Like this is an ongoing action we are all doing. So thanks all so much for your time. We're now going to introduce our next speaker, Dr. Carrie Ernst, to talk about mentorship in the DEI space.
Thank you, John Dunn, and good to see everyone here. So I think as we begin to talk about mentorship in the DEI space, it's important to be able to anchor ourselves in some of the workforce data as we think about who we need to mentor, who's available to mentor, and what our patients ultimately need in terms of healthcare providers. Looking at the data is helpful. So if we look here at the data, and this is data compiled from a number of sources, but most of this data is from the AAMC, like the workforce data that they compile, both from the resident report, as well as like their faculty report and their physician workforce data, and comparing that data to the US Census Bureau from 2021, the most recent data that I could find. So we look as our population in the US gets more and more diverse as we think about what percent of our population is from groups that are traditionally marginalized or underrepresented. Those numbers have gone up over time, but our numbers in medicine have not increased proportionally. If we look at medical school graduates, we see, for example, that in 2019, only 5.3% of medical school graduates identified as Hispanic, Latino, or Spanish origin, 6.2% identified as Black or African American. Those are much lower numbers than the percentages in our US population. And I think, at least if we look at psychiatry residents and actually look at CL psychiatry fellows, we're doing slightly better than medical school graduates in terms of the percentage of our residents and our fellows who identify as members of different groups, but still numbers that don't approximate what is in our population. I think, though, as we think through, who is available to mentor our trainees, what faculty will be available as we look. If we look at, this is workforce data from U.S. medical school psychiatry faculty, so psychiatry faculty in academia, we see that the percentage, the representation is much lower even than our medical school grads and our psychiatry residents and CL psychiatry fellows. So we're really not able to match our faculty and their identification with our trainees. And I will also say, if you look at medical school faculty, a lot of these numbers also represent junior faculty. Then we think about like full professor level, associate professor level, we see even less representation. So we do have this dilemma where we do have, patients that, we need to take care of, and we have trainees that we need to provide mentorship to, but we don't have enough people in our mentorship pool to provide that mentorship. So that's some of sort of the reasoning behind having this conversation today, to begin to think through, how can we expand the available pool of people who can mentor our trainees. And this is workforce data, just looked at it another way from a paper from a couple of years ago, just graphically, again, showing you, some of like really the disproportionate, we see the rise in the US Census in our population, but how this is not accounted for in our psychiatry faculty and medical school graduates. If we try to break it down by specialty within psychiatry, this is data that's a couple of years old at this point. This is from 2016, but it is interesting to look at, what proportion of psychiatry residents and subspecialty fellows identify from different groups. And, one thing we can see is that, in addiction psychiatry and forensic psychiatry, the numbers are lower than a number of the other specialties, both in terms of people who identify from groups underrepresented in medicine, as well as people who identify as female. We can see in CL, we're sort of right here in the middle. Oh, this pointer doesn't work. I don't know if this works either. Okay, so we can see in psychosomatics, we're right here in the middle, about 52% female, 16.9% of fellows, at least from this study, identified as underrepresented in medicine. So similar, geriatric psychiatry probably has the best, most diverse representation in terms of their trainees. So something to think about as we think through recruitment. And then, a point to make just in terms of our faculty, this is looking at really like a 20-year bird's eye viewpoint of faculty within psychiatry academic faculty, and you can see that with slight exceptions, the numbers really haven't changed that much in terms of percentage of psychiatry faculty who identify from different groups. So maybe some slight increases of a couple of percentage points, but 20 years is a really long time, and we certainly have not seen large increases. So this again provides certainly a dilemma. Many of you have probably heard the term leaky pipeline or the leaky pipeline to academic leadership. This is not specific to psychiatry per se, but this is, I thought, was an excellent slide. Which really, I think, graphically shows you, like looking at medical school applicants to matriculants to residents to faculty to the full professor level to the dean level. We see that we lose people, at every phase we lose people. And why am I telling you this? Because the lack of mentorship is one variable that's been suggested as a structural barrier for improving the diversity of our physician faculty workforce and stemming this leaky pipeline. And when they have interviewed many people who have come from different groups that have been historically underrepresented in medicine or marginalized in medicine, one thing that people have consistently said was, I need more mentorship, and we don't have enough mentorship, and mentorship would help me get where I want to go with my career. Why is mentorship important? There are many, many benefits, and many of these benefits have been borne out in the data and the literature when you've looked at outcomes of mentorship programs. People who have mentorship find, enhanced career building. They find that they're more successful in promotion, they're more satisfied in their careers, they're more academically productive in terms of getting grants and publications. People who have mentorship feel like they belong, that may lead to better retention, more confidence, feeling like you are working with people, you have people who share your identity, and they feel supported. They feel like they have a good support network, that they have a safe space, and they feel prepared. They feel like they have the capacity to mentor others, because I think we're also thinking about paying it forward. Why do we train people? Why do you join a mentorship program? The hope is like once you're a mentee and you've been a mentee, you also will then go and mentor others. So that is one thing that's really important. You'll have a role model. That term role model came up on the word cloud a number of times. And it's also important, mentorship, for teaching you the unwritten rules. How do I navigate an organization? How do I navigate an institution? Like, what do they not tell me at orientation? So these are all things that are really important why people do need mentorship. But unfortunately, there are disparities. If you look at the literature, if you look at female physicians who identify as LGBTQ, physicians who identify from underrepresented in medicine groups, they're less likely to have mentors in general, both as trainees and as faculty, because faculty need mentors as well. And what often happens is people are asked to mentor without having been mentored themselves. And that's part of the minority tax that we talk about too, that if you're from one of these groups, often you're asked to mentor younger trainees, students, residents, maybe even high schoolers, but you've never been mentored or you don't have mentors. So you're being asked to take on these things without, having had the benefit of mentorship yourself. In this space, and Lena will talk a lot more about this, sort of giving like tips and suggestions for this, but when we are mentoring in a space like a DEI space, there are some unique issues that mentors have to address, whether mentors have shared identities that align with their mentees or not. They do have to be able to address inequities, the fact that there are inequities in like promotion and compensation and being asked to do non-career advancing activities, the minority tax. Like, a mentor has to be able to provide guidance to a mentee about that, right? A mentor also has to be able to provide guidance to a trainee who's experienced marginalization, discrimination, or bias, like an unsafe space in the workforce, chronic microaggressions. A mentor has to deal with the fact that there's a limited pool of mentors and a limited pool of peers as well. So how do we help our mentees to feel not isolated, less excluded from things, feel like they have allyship? Lena will talk about imposter syndrome too, right? If you're mentoring in the space, you also have to be able to work with the mentee who may struggle with imposter syndrome, and that's probably linked to leaving academia. People are more likely to leave academia if they identify with groups that are traditionally underrepresented in medicine. And then as a mentor, you also, your mentees in the clinical workspace, there has been data that shows that, mentees who themselves identify as from marginalized groups are more likely to treat patients from marginalized groups. And often that work might be less well compensated, or the patients may have more complexities. And, often there's not adequate compensation or reward or protected time to do that work. So these are all things, to be thinking about as we progress through this session for how we can teach people to mentor. Just from a data standpoint, there is some published data on mentorship programs, programs that specifically are geared to mentoring women in medicine, programs that are particularly geared to mentoring physicians and trainees in medicine that are from underrepresented in medicine groups. And there are some good systematic analyses of multiple studies. And while it's hard to derive outcome data from this, because it's very hard to compare between programs, you can imagine that a lot of these mentorship programs are like at one institution and they're very small. There are some themes that have emerged from the data for both. And a lot of these are shared. So, the idea that institutional support is critical, that for mentorship, the onus really needs to be on the institution, not on an individual faculty member or department to provide that mentorship. Also, mentorship programs should be tailored to the institutional needs, like what are the gaps, what are the needs at that institution in order to optimize resources. It's really important to train mentors to ensure effectiveness for all mentees. So you can't just throw people together and say, we're going to develop a program, mentor this person. You actually have to provide that training. Interestingly, when you look at identity concordance, if your mentors and mentees do not share the same identities, is that something that impacts satisfaction? And across the board in these studies that have been published, both for women in medicine and underrepresented physicians in medicine, it's actually been shown that lack of racial or ethnic concordance or lack of gender concordance did not adversely impact satisfaction. That at least in those studies, people still derived a lot of benefit and satisfaction from the mentorship programs, even if their mentor didn't share their gender or their race or the ethnicity. And the programs in general were shown to improve promotion and retention. I will say that most of the mentorship programs focused on junior faculty and trainees, and that's something that I think a lot of us have been thinking about. Where is the mentorship for the mid-career people or later career people? Just a word about identity discordance, because I think that is something we're going to talk about, since I mentioned that we have a smaller pool of faculty mentors, and how can we and disparities in who gets access to mentorship. So given that the literature seems to suggest that mentorship can be effective even if you don't share a background or identity with your mentor, training very much is needed, and training is needed to address all of the sort of unique attributes and disparities that we talked about earlier. The last thing I wanted to say is, that said, despite the literature about, people have satisfaction even if their mentors don't share their identity, the mentorship subcommittee, which I run, runs a mentorship program. And this year, for the first time, we asked people applying to be mentees as well as mentors, we asked an identity question in the application. And it was optional, but it basically asked people, if there is an aspect of your personal background or identity or a particular community that you are devoted to, that you wanted to share with us to help align your interests with that of a mentor, please let us know. And what we found, interestingly, that of the mentees, so the mentees were mostly residents, fellows, and early career psychiatrists, a couple of medical students. Almost half of the mentees responded to the identity question, actually far fewer than our mentors responded to it, and responded very, very specifically. I just put a couple of anonymized quotes here. This is not a scientific study, but just to show you what our trainees and early career psychiatrists today are looking for in their mentors. I am the first in my family to go to college, much less earn a doctorate degree. I am a mother of 2 children. I'm hoping to connect with a female mentor who also relates to the experience of motherhood, especially as it relates to balancing parents and parenting and training. As a female Latina, first generation immigrating to the US and first generation scholar, I face multiple daily barriers and notice gaps needed to fill when it comes to navigating a career in academia. So our mentees today are looking for mentorship, seems to be, at least in our small sample of 100 people who applied for this program, are looking for mentors with shared, personal and professional identities. So it is something to think about going forward, that even in the literature shows that people can benefit from mentorship programs regardless of identity of the mentor. I thought we all thought it was very striking to see what our mentees were asking for. And then my very last slide is given this, and given that we don't always have enough mentors, thinking through novel models of mentorship. You'll hear Carlos talk a little bit later about one example of a program, but there have been a couple of models that people have looked at, including a cascading model. This was a study that, looked at high school students, pre-meds, med students, faculty, but this notion that, you can have pre-med, like in this study, they had pre-med undergrads mentoring high school students, not a one-to-one dyad or one-to-one relationship, but maybe you had 3 pre-meds mentoring a cohort of 10 high school undergrads, and then maybe you had 1 med student mentoring that whole family of mentees, and then you had 1 faculty member. So there are ways, to sort of think about mentorship in a cascading way that also can account for not having enough mentors. And another model was sort of a peer on-site distance model where the mentee actually had 3 different mentors: a peer mentor, so someone sort of at the same level of training or experience, a distance mentor, someone who wasn't part of the academic institution but could serve as a mentor, and then somebody else who they called it an on-site mentor, someone who was actually on site, who was more senior. And the rationale behind this was that each mentor then could take on a smaller role. They would mentor the mentee about one particular area, so it was really very much shared. So those are just some things to think about as we think about what's in the literature and how we can improve things and make a difference going forward. With that, I'm going to turn it back to Sarah and to Chandan to do some of our small group discussion. Thank you.
Hello. So right now we're going to move into a small group discussion for about 20 minutes. So we're basically going to split into the 2 sides of the room. So on this side, Dr. Sarah Nash is going to be distributing case number 1 of applying some of the things we've learned so far, and I'm going to be leading the discussion on this side for case number 2. We will each, as a group, pick someone to then start taking notes on our findings, and then we're going to come back as a big group and share what we discussed. All right, so let's circle up. Yes. Groups just present their findings.
Okay. Okay. So hopefully we have a scribe from each group. For the people who were in group 2, this I can show you the case for group 1. And do you want to come up to the mic and share what group 1 came up with? I don't know, the mic is on?
No? Yeah.
There we go.
Does everyone have the same first 1 to 5 questions? Do I have to read those
The
out?
questions are the same, yep.
Okay. So for this patient, for the first question, we were thinking about how how patients and the DEI framework intersect. I think we think a lot about peers and colleagues, but how do patients fit in? We also thought about who might be impacted by a patient acting like this or saying these types of comments, like med techs, nurse, the physical therapist who's there, or other patients who might be the patient's roommate or down the hall, and how do we consider them when trying to make next steps for this type of situation. For the second question, the role as the mentor to validate the experience of the PGY2 resident, acknowledging that they took the step to report it to a superior resident, the chief resident, also talking to the faculty person now, and then also thinking about modeling boundaries and having a script for that, which goes towards the ally part 2 for us. Thinking about putting your arm around the trainee and going back to the room and having the conversation with the patient of, we're on the same side, we're trying to help you, but we won't have you talk to our trainees, peers, faculty, anyone else like this. And also kind of validating too that the trainee might struggle with imposter syndrome, and also bringing this up can be a tough thing to talk about. So acknowledging the patient or the trainee is meant to be here and is a good doctor, those types of things. For the fourth part, we said, discussing with peer leadership. Oh yes, thinking about other people who like might interact with this patient. If there's a surgical team that like might be at risk of having this type of interaction, having their division leaders, nurse managers, other people like aware of these types of situations to have a conversation proactively or acknowledge that people might have had these experiences in the past and not brought them up. In psychiatry, we talk about these things, but not everyone does talk about these things. And then this can be a conversation starter, having a blunt conversation with the patient. And then lastly, from a systems level, could think about like involving patient services, i.e. the hospital, and like having like a hospital-wide patient bill of rights or responsibilities, how to treat staff in the hospital, or kind of like having them on your side to say like, we're just going to treat them until they're stable and then discharge them, which brought the conversation up of like, how are you just kicking the can down the street to some other hospital, or is this like boundary setting actually teaching a lesson or not? So there's no real answer for that. But that was it.
Thank you. That was a great summary of a really rich discussion. And for those people who were in group 1, you can read case 2 and great, fill us in on what your group came up with.
So, so the gist of our case was,
Maybe speak a little more into the mic so the folks who are watching virtually can hear.
great. So the gist of our case is a younger faculty who's come in. Sure. That's that good? Yeah. Who's going to their division chair for some mentorship, burned out, related to sort of being treated monolithically in regards to their different aspects of their personhood. And so the DEI problems we identified were assumptions being made about the interest and willingness of the junior faculty member based upon their diversity alone, tokenism, it's insulting based upon the assumptions, the minority tax, they talk about the burnout being related to doing all these things, not being compensated for it, after not being asked if they really even wanted to do these things. There's a lot of power language in line with a power hierarchy that does not appear very approachable. They're being told what to do, manipulated. There is no exploration of individual desires. There's devaluing of their efforts by not having compensation or being able to buy out clinical time. There's dehumanization, objectification, oversimplifying diversity as a concept, and then there's the lack of a DEI belongingness or community. And what is your role as a mentor? Look at the person as not simply a representative of you are, I am, investigate values, one's strengths, weaknesses without assumptions, seek consent, make a shared plan, explore and make a plan related to burnout, work with mentee on how they might approach it themselves with the department chair. What is your role as an ally? Seek consent, make shared plan as an ally. Are there other mentors or allies with more experience with navigation of these types of obstacles, both visible and invisible? People who look like me and are like me don't experience this and have very little experience with it directly, but can learn, but still may not be as suited. Approach the chair about the situation as feasible as an ally. Can address sponsorship with the departmental leadership around actual mentee desires clinically, in this case, neuropsychiatry. And then action items as an individual, we talked about those a little bit already, and then you could potentially go with a mentee to participate in a discussion, and then at a systems level, liaise with DEI groups across the hospital system related to these types of experiences more broadly, how they're responded to, address DEI belonging, community that is effective, I added this one at the end, increase diversity among faculty, recruit more senior faculty who are diverse, so you can have mentees that, or mentorship that is maybe more experienced.
Thank you. And I think that, in both of these cases, I didn't hear the discussion for case 2, but the general response is, this is not surprising. And so I think that if we're sitting here and we're reading these cases and these are all based on real things, right? This is not surprising. This is not shocking, but it should be shocking, even if it's not surprising. And there may be ways that we can work with our own ability to be mentors and allies. And to that end, I'm going to pass it along. If we have time at the end, we can come back to this, but I want to pass it along for ways that we can think about how we can be better mentors and allies.
So I am going to sort of try to do a, excuse me, sorry, a frog in my throat, a sort of whirlwind tour through this concept of really trying to expand our use of the term trauma-informed to expand into our professional interactions too. We talk a lot about trauma-informed care. In so many ways, it's really become part of many, many organizations, but really how are we applying those concepts to our roles with interprofessional interactions? I have no financial disclosures, but I just always like to start a conversation about identity with a few other points about disclosure. So I identify as a woman of color. I identify as a cisgendered heterosexual individual who is part of an interracial marriage, a psychiatrist, an educator, an administrator. So I have all of these roles, and so many of them, there is a component of intersectionality that we have to acknowledge, that my experience isn't necessarily the same as somebody else's experience, but I can experience and walk through my professional space, and I have to also make decisions about what I disclose and what I don't disclose. Some aspects of people's identities that may lead them to feel marginalized may not be part of what they want to disclose and talk about explicitly. And so we have to be thoughtful about the fact that people are experiencing marginalization, our mentees, our trainees, our colleagues, our mentors, may not be able to disclose everything. There may not be a safety about disclosing all things. And so that's really about a universal experience of creating space for anybody who may experience marginalization to feel safe and cared for and professionally have the opportunities to be in a professional space equally. And I think we also have to, in this, talk about the risks of disclosure too. So there are ways in which people who begin to talk about their identities, begin to talk about gaps in the system, may actually also be at risk for increased scrutiny in the context of their identities or in the context of the questions that they're raising. And so we're always doing this kind of risk-benefit analysis. There's this really great, when you see the slides, there's a reference to a TED Talk that's really, really great talking about the risks of disclosure. And the reason that I think trauma-informed care is so applicable to this conversation is because we talk about trauma-informed care as a set of universal standards or universal precautions. And we also have to acknowledge that walking through life experiencing marginalization or racism or discrimination really is a cumulative experience of trauma. And so in thinking about the principles of trauma-informed care, we think about the cultural, historical, gender context that all of us have experienced in different ways, establishing a sense of safety, trustworthiness, and transparency, peer support, collaboration and mutuality, and then empowerment, voice, and choice, which are, I would say, like the 6 sort of core principles of trauma-informed care. So I'm going to focus first on the sort of cultural, historical context. It's incredibly important for all of us to acknowledge the personal history and historical context of the mentee and the identities they come from. This concept of death by 1,000 paper cuts, the experience of the daily microaggressions that can happen depending on, again, disclosed or undisclosed identities, are part of what a mentee is walking into a mentor-mentee relationship with. And it's important to also acknowledge that people who are part of a marginalized group are facing a particular complexity where they're, acknowledging their past and the future of those with their same identity. There's the sort of shared pain and collective trauma of marginalization, but also gratitude for the support and the things that have helped support that particular individual and what may be facilitating their career. There's concern about future, paving the way for others, making more opportunities, and then also maintaining their own well-being in the face of challenges. And so when you're talking with a mentee, it's so important to acknowledge all of this is going on, all of this is in the room with you. And also, it's really important to kind of, there are a lot of different ways to think about mentoring. And I think we're really moving away from this concept of cultural competence and really more about cultural humility. But really, all of this is better than tokenization. This is a conversation that came up clearly in the cases. And it's important just to be thinking about this in the context of a mentor-mentee relationship. Also, really important to acknowledge the structural barriers and systemic challenges that are in the system that you two are in and sharing, and work to address them. We've talked a lot about imposter syndrome. This is a really useful article in the Harvard Business Review that I think everybody should read. I think that imposter syndrome is important to acknowledge, but I think it's also a concept that I think does not facilitate us really looking at what are the contributors. So imposter syndrome was coined in the context of interviews with white women in a professional setting. It did not, the original definition was described with a group of people who, and they did not ask about experiences of discrimination or experiences of xenophobia, but really about their own self-doubt. And so it sort of puts the locus of control in a way, or the pathology inherent to the individual experiencing it, and not the system that creates the images of what a leader looks like or what a competent individual looks like, and it eats it away and erodes confidence. And so it's really bias and exclusion that increase or enhance doubt, and perhaps more so, disproportionately more so, for marginalized individuals. And so really, in this article, there was this very, very clear concept of the important thing to do is address the bias, and address the structural issues, not fix the individuals that are impacted by them. And so I think it's a useful rubric to think about sometimes. Now, safety is, of course, absolutely necessary in any mentorship relationship. And mentorship requires an environment that enhances psychological safety and a culture of generativity and reciprocity. And so in this randomized control trial comparing two, this is again like from the corporate setting, two approaches to mentorship. They compared essentially what was called a broad mentorship condition to an opt-in mentorship condition. So think about, raising one's hand to say, I'd like to participate in the mentorship program. Who is more likely to opt in? Who is more likely to raise their hand? There are a lot of structural factors that might enhance somebody's confidence or willingness to opt in. And what this study showed was actually those who opted in, I'm like not advancing. Those who opted in were people who were likely to benefit the least from a mentorship program. So in the context of broad mentorship, the outcomes for that particular organization were actually that those who participated in broad mentorship, where the mentors were trained and everybody was assigned a mentor upon entry into their job, productivity for all people and for the entire organization increased, revenue increased, because this was a corporate setting. And so really it's important to kind of think about creating, again, a culture that mentorship is the standard and not one where those who are most comfortable raising their hand can continue to get more resources. And also, it's important to acknowledge that formal mentorship programs are actually better for women and individuals who identify as people of color. Another example being a study described by Johnson et al. In the Harvard Business Review. Now, trustworthy and transparency. So I think that it's in particularly important to both foster transparency within an organization and build trust within a mentorship relationship. And so in order to do that, I think there's this sort of hidden curriculum that it disproportionately impacts women and marginalized individuals. And so we often talk about the sort of the power of the behind closed doors conversation. Really, I think the job of the mentor, especially when you're mentoring marginalized individuals, is to open the door. I was having a conversation with somebody who actually said that sometimes I don't even know those doors are there, let alone that the conversations are happening behind them. And so it is the job of the mentor to share the hidden curriculum, the organizational structure, the culture, how decisions are made, where is power held, what is the best format or type of conversation to have. Salary transparency is another part of this. There are marginalized individuals, people from different racial backgrounds, especially those who are underrepresented in medicine. There is less generational wealth. There is less opportunity. There's already salary gaps. So salary transparency is a way to continue to advocate and facilitate for your mentees. And then I think the other part of transparency is being honest with yourself, examining your implicit biases, taking the implicit association test if you haven't, taking a stance of humility, and then also acknowledging that allyship can suffer from what's called an aspiration execution bias, where people who think they're allies they think they're doing better than the ones who benefit from allyship actually think they're doing. So in this study that was sort of independently done by a foundation called the Integrating Women Leaders Foundation, they did a study within a corporate setting again, where they asked the men in the setting, how good of allies are you? And the women who were also asked then said, how good of allies are the men? And there's a pretty significant gap among all measurements. Men who were more likely to view themselves and other men as active allies more so than women were actually likely to categorize them. However, the other thing that this study showed was that those who participated in active allyship training did in fact do better. And so there is hope, there are skills. Also, and McKinsey does a yearly Women in the Workplace report, and it looked at then looking by racial breakdown, white employees recognizing the need for allyship, but not being able to actually identify specific tasks that are seen as allyship, whereas individuals of color, when asked to rank the tasks that were most important, really ranked advocacy and mentorship much higher than their white counterparts. Peer support is also part of trauma-informed mentorship. There is an additional harm that's done when people are in the experience of being the only of whatever identity they are in. There's increased scrutiny, increased othering, and then there is again the sort of role of intersectionality. So being the double only, as this report in the McKinsey report sort of coined, the intersectional identity is actually the challenges, the scrutiny, the isolation is greater, the sum is greater than its parts. And so the sort of double only or double exclusion. So again, the need for peers and facilitating peer mentorship. Collaboration and mutuality. Mentorship is about reciprocity, engaging in exchange, not talking at your mentee, but really listening, thinking about the reverse mentorship concept in all mentor-mentee relationships. The goal is not to create a clone of oneself, but to listen, acknowledge one's power, privilege, positionality, and share that those things. And the last piece is empowerment, voice, and choice. So really like autonomy, facilitating the mentee's autonomy. The mentor, again, you're not making a clone of oneself as a mentor, but really fostering the mentee to grow into their own vision. So affirming their identity, creating a space to talk about one's identity, fostering autonomy and avoiding this notion of saviorism. Not assigning oneself as a mentor, but really inviting people to see them as a mentor if they so choose. So the difference being, I'm so-and-so, I saw your presentation at ACLP and I'd like to be your mentor is very different than saying, hi, I really enjoyed your presentation. I really want to learn more about it. Come talk to me. Here's my card, or here's my, I don't know, cards. Like, I'll airdrop you my details. And so, that's a very different way of engaging a mentor-mentee relationship. It is the choice of the potential mentee to decide what kind of mentorship they want from whom and around what topics. The former approach really not acknowledging power, positionality, and sometimes intrusiveness. And another way to really think about affirming the mentee's vision for themselves is through loud sponsorship. So loud sponsorship is a way to think about sponsorship with a couple of steps, the ABCDs. Amplify the perspective of the mentee and the experience of the mentee. Step out of the spotlight and hand the mic over to them. Boosting the mentee or the protege, formally putting the mentee forward, writing agentic letters, seeking out opportunities, putting names forward, adding people's names into like the hat and putting their names in the ring. Connecting, so explicitly naming the relationship of mentor-mentee, explicitly connecting yourself, using a little bit of social capital by aligning yourself with the mentee. That is allyship. And defending the mentee, actively dispelling negative impressions. The question to ask yourself whenever you hear negative discussion about your mentee is not whether there's bias happening, but how is bias at play here? And that's, I think, the role of a sponsor. So in summary, really the goal here is to acknowledge the context that mentees are coming through, commit to addressing the structural barriers that are in the relationship and in the institution where you're mentoring in, engage in some self-examination around your own biases and find ways to practice humility, share knowledge, share power, share positionality, engage in reciprocal learning, affirm the mentee's identity and vision, and engage in loud sponsorship. So thank you. I'm going to hand it over to Carlos.
Hi, everyone. Thank you so much for participating in this workshop. I'm in charge of the last part of it. So this is more of a capstone conversation. This is I'm a psychiatrist. I'm in Boston. I work with Brigham and Women's Faulkner Hospital. And over the past 2 years, I took part of a mentorship program that was focused on underrepresented minorities. And I'm basically here to tell you my story on this. Nothing to disclose, unfortunately. So far we have covered all the important aspects of mentorship and the important aspects of mentorship in this relationship with unrepresented minorities. But it comes down also for this part is, so what about the mentors? What do we do for the mentors? And we were in that position about two or 3 years ago. Basically, our origin story is 2 or 3 years ago, I was with MGH McLean, and the residency program was transitioning their associate director, and she put us all in a room, everyone who was involved in these kind of initiatives and were like allies on the DEI efforts. And she was basically, how can we do best for our trainees? And over the past few years, the training director, Scott Beach, he had transformed the entire composition of the residency class, and it was way more diverse. So how do we step up to be supported? We brought them here. We want to make sure that that we do the best for them, not just kind of to make it look nice and meet the diversity, but how do we really step up for that? And we start working on different tasks. My task was to kind of figure out what was the best, how to improve our anonymous reporting system to when something happened. And on that conversation, it was just basically like, well, first of all, it's never going to be anonymous because they're going to know who was rotating that. And it's not about reporting, it's about trust. It's about like looking at the people who's out there and know that we have those allies with us. And I never saw myself as a trailblazer. I never saw myself as someone who, I opened and I was a trailblazer by being a minority who went into an academic place. I never identified with that. But then those conversations and those readings that you've done about, it's okay, it happens. Those conversations that you have had about representation suddenly click in my head and like, I am the representation. So I need to step up for them. And it happened to a lot of us who were in that group, and the residents were asking for mentorship, and we said we have to do something. We have to really put something together for them. So Enkechi basically kind of recruited psychiatrists who were part of minority groups that were active in the city of Boston, and she looked also to some of the graduates who were across the country. And she found out who were interested in this, who really wanted to be part, who really wanted to take part of this. And she put us all together and assigned us with the different trainees. So we were going to be the mentors. And if you are like me, you're like, well, I never got mentorship training when I was in my residency program or my fellowship. And how do I do a good job about this? And what we did is we put a curriculum. Enkechi put a curriculum. I just took part of it. And this was the curriculum that we got there. And it encompasses not only DEI aspects of this, but we went from the basics of being a mentor and to the more challenges part of it. Like how do you provide How do you address a crisis of identity? How do you really provide feedback when things are not working for the mentor, so for the mentee? So it was a very, very invigorating experience for us. We went through those conversations once a month. We will meet on a Zoom visit. This is a picture of that. And we will have guest lecturers from Boston, but we also they reach out to New Haven, and we reach out to North Carolina, and we got a lot of people who were like sharing their experiences and sharing all the work that they've been doing around it. And it was not just classes; it was also a space for sharing our experiences, to be vulnerable and say, well, I don't know how to do this. I don't know even how to force this, and to do what you just did, role play some of the situations so you should learn and grow. And there were tons of lessons from that, but being mindful of time and being mindful of how we learn, kind of put it together into 3. And you're gonna find out that this relates to what has been spoken already. So the first lesson is, and I might have been watching the movie Taken when I say this, is a particular set of skills. And that means that being a psychiatrist, being a good psychiatrist, being a good clinician, a good researcher, a good educator, doesn't make you a good mentor. And even being a good therapist doesn't make you a good mentor, because there's a different set of goals here. So it is a good idea to learn the basics of this. And it's a good idea to train everyone who you put in, you're in charge of a program. It's a good idea to give them at least the basics. For instance, in planning, it's important to explore, why are you going into this process? What is driving you to be a mentor? What are the things that you need to know from yourself, understand from your motivations? So you either capture that or put it aside if needed. What are the different mentorship styles that exist? Like which one do you identify with, and how do you can pull from the other ones when you need to? What are your own limitations? What are your limitations from time? What are your limitations from commitment? How are your own internal limitations from your identity to get into that process? How do you set up that relationship for success? What things can you do to develop as a mentor and to set the expectations, the goals? How do you set boundaries with your mentee? How do you talk about your limitations with the mentee? And what are the different tools that exist that can help you in that journey? Like, for instance, we got a template of a mentorship agreement that was super helpful for me to kind of have those conversations. We learn a lot about the different type of language strategies or communication strategies that you can use with your mentee to kind of be mindful of all the things that are happening in that relationship, and what other tools exist there. For instance, I tend to gravitate to being a connector mentor, and I like to connect people with my network, and I have to leverage my network to help the people that I am around. But for instance, on that conversation, we talk about this constellation of success, which is, it helped me navigate and map my mentee's network and leverage her mentees. And kind of in that way, I explained I was being more effective as a mentor just by using this technique that I previously had no idea, and I never saw any of this in my residency training program. So having those tools and giving those tools to the mentors that you have in your program is super helpful. So the second lesson, in case you haven't heard it, sharing one identity is not enough. We just said it at least 4 or 5 times, and I hope that this is the one that sticks. We all have multiple identities. Again, I'm Colombian, I'm a male, I identify with a he, his pronouns. I am an immigrant who came in his 20s, so I did not grow up as a minority. I'm not particularly in research. I'm more in the clinical aspects of care. So there are many things that I don't share with my mentee, and I have to be mindful that just because we both are Hispanics, I don't understand everything that is part of her. So that's things that you have to be thinking on that, and you have to learn about it. So reflect and contrast all the identities. Be aware of the biases that your identity is bringing to the relationship, and be aware that how that can affect the dynamic in the conversation, and acquire the proper language skills to address it. Be able to kind of know how to speak to this, how to humble inquire, how to kind of be mindful when you're engaging in the conversation with your mentee, so you can protect her, you can actually help that person develop. Learn about the different experiences. One of my colleagues was mentoring an Iranian female residents who they were talking about a little bit about what was going on, and not right now, but in the past with Islamophobia, and he completely was totally missing all the things that happened in Iran with the revolution that happened 30 years ago. That was like completely missed, and like you have to understand those things to be able to be a good ally and not miss the big parts. And this part that you just did about role playing and actually preparing yourself from when those crises of identity happens and having the answers is super helpful, because you cannot think that because you are aware of it, because you have read and informed yourself, you're gonna be good at addressing it in the moment. And having a space to be vulnerable and kind of stumble your way through it help you tremendously when you actually have to do it. So that's the lesson two. Don't take comfort in your shared identity and kind of inform yourself about it. And the last lesson is the mentee's development is what is the most important thing. And there's some do's and some do not. So obviously do ensure that you're doing trauma-informed mentorship. Do humble inquiry. Providing feedback is super important, and something that kind of can be not in your conscious, in your immediate level of awareness. You as a mentor are responsible for the emotional intimacy that is going to develop and to be able to address it and protect it in the right way. So those things, I acquired them through this mentorship program. It was super helpful for me how my relationship with my mentee developed. The do not, it's, how you say this is, you're not Dr. Evil from Austin Powers, you're not creating a mini-me, you're not cloning yourself there. It's about developing the career of that person. It's about what their needs are. You're not, that person doesn't have to follow your steps and do exactly, you don't have to be a CL psychiatrist, who's a psycho-oncologist, you don't have to do the same things that you did. You just have to help that person find themselves. You want to protect this person when it's needed, but you don't want to protect for everything. You're not just kind of pulling bubble wrap. You need to know that for development, sometimes they can have to make mistakes. And you're not the problem solver. You're not the person who's going to do all for them. You're going to have to learn them, teach, and sometimes it can also involve let them fail at some things and find their own answers. And last, I'm surprised, but apparently this is very common. As a mentor, you should not be claiming their success. The fact that a trainee is successful, it just speaks about the trainee, and sometimes mentors apparently do that. That is just kind of claiming the success the trainee has their own, which is extremely awful and extremely harmful. One of our speakers talk about how she has a Black woman who always having these other white females saying, I'm going to mentorship you, and when she was successful, some of them were trying to claim that from them, which is like, this is something that is a big no-no, but it really needs to be reminded. So, to conclude this part, I cannot speak to how wonderful it is to be a mentor, and for people who is responsible to put in programs, just make sure that you define the goals very carefully, that you do the program have be an opt-in, like you want to have really people who really wants to do it rather than have everyone force me to be a mentor. Just, I'm going to assign you a mentee. No, people who really wants to be a mentor should only be there. That part, try to be quality over quantity, acknowledge that there are going to be challenges, create a safe environment for everyone, particularly for the mentors to be vulnerable, and invest in training, the basics, the identity part that needs to be very well trained, and how to make sure that you're putting your mentee for success. Thank you for this, and now we want to have some time for reflection. I'm going to hand it to Shannon.
So it is 12:32 right now, so we're 2 minutes over. So one thing we just want to ask you to do is think to yourself, based on all the things that you've learned right now, what is one action item you just want to do for yourself once you leave of this place? Thank you all again for coming to our talk. Thank you all for participating. This is like one of the funnest workshops I've had the pleasure of being a part of, and wish you all the best. Glad to see you all in person again.